Now I invite Dr. Mathew Kurian, Senior Cataract Surgeon, Chaitanya Eye Institute, Ernakulam, to deliver his talk on dealing with intraoperative positive pressure. Over to you, sir.
Thank you, Dr. Sara, for having me. So this is something that happens infrequently, and the most important thing to remember is to recognize it. Because if you fail to recognize it in the early stages, you will be losing the opportunity to manage the condition without too many complications. So central and peripheral shallowing of the anterior chamber happens, and because you're doing it from an en-face view from the microscope, you may not realize how anterior it is. You may end up with side port, main port, or any other instruments either hitting the capsule or the iris. So commonest cause is aqueous misdirection, where normally the ciliary body is rotated posteriorly. There is adequate space to for the fluid to go through the angle, but here it goes into the Berger space and pushes the lens iris diaphragm entirely forward and causes a pupillary block. So this results in a flat anterior chamber, angle closure, and eventually raised IOP, which needs to be managed. UBM is the best way to detect this, where there is anterior rotation of the ciliary body. The angle is completely occluded over here. The ciliary body, which is back there, is now rotated forward, and the iris cornea angle is close to zero. Management options. If it is aphakic or pseudophakic, you can just go and either limbal or pars plana, you can enter into the Berger space and withdraw the fluid, which is a little bit of a guesswork, unless you have intraoperative OCT or something like that. Or you can do vitrectomy, either anterior approach or a pars plana approach. So what they say is that preliminary vitrectomy is to debulk the vitreous and soften the eye, phacoemulsification to be performed subsequently, then finally complete the vitrectomy with the zonular hyaloidotomy and peripheral iridectomy, and you want to create a single anterior posterior segment space. So that is the PI is done, and through the PI MVR blade is introduced to go through the zonules, and then the anterior vitrectomy cutter is passed posterior to the capsule. Make sure that you are not damaging the capsule, and do a limited core vitrectomy. Little bit dicey situation, and I will explain why. So this is one of the cases that I had. Fairly high hyperopic IOL powers, axial length is small, and I had done the left eye, the smaller axial length eye, without too much of difficulty, and I was now doing the right eye. So let's see what happens. Iris is billowing, iris, this is viscoat I had placed already, and during that time also iris billowing, and during IA the iris is prolapsing out. Again put viscoat to tamponade and try to prevent the iris from prolapsing out, and then medium-sized nucleus, but phaco was proceeding pretty much uneventfully, and I thought, okay, I managed this, no problem. Okay. Folds on the posterior capsule, and then it becomes hard, iris is prolapsing, side port also is plugged. I thought I'll release the speculum pressure, whether that is the cause. Not much use, viscoat is coming out, hardly anything is going in. I have to put the IOL inside, push it in anyhow. Okay. Leading haptic goes into the bag, optic opens, trailing haptic is in front of the iris and does not go in. So then I thought I'll do this cut down method, and by the time patient is experiencing pain, wincing and all that, 1 millimeter behind the limbus, just make a small peritomy and try to do a sclerotomy. Some blood oozes out, and I think, okay, this is going fine. Try to reposit the trailing haptic into the bag, not working. Rather than create a PC rent, I decide I will go and do this limited anterior vitrectomy in the burger space. So I'm cutting, and cutting. At this time, glow was still normal, but now glow starts to alter. And you can see the retina is, entire thing has come up. So at this stage, quickly abscise whatever remaining of the iris is there. Patient is wincing, very uncomfortable. Somehow suture it, even though there is little bit vitreous, iris there, small heme coming there, inside the anterior chamber, close, get out. So what were my learnings from this? Hollade says that it is not just long, normal and short eyes. There is also proportionately smaller anterior chambers, normal anterior chamber and large anterior chamber, and about 9% are short, out of which 2% have got a proportionately crowded anterior chamber as well. Challenges in the longer one are much less, and the risk of intraoperative hard eye is very much higher when you have a small or crowded anterior chamber, maximum being when the anterior chamber as well as the axial length are both small. So let's look back at my first patient. So here the axial length was small in both eyes, okay, so that is short axial length. But in this eye, the white to white was more than 11. So in the shorter axial length, the white to white, so the anterior chamber was not as crowded, and so this was axial hyperopia, while this one with less than 10.75 millimeter white to white, it was actually a non-ophthalmic eye. So what are the intraoperative challenges in non-ophthalmos? We have to look at these things to realize that it is a problem there. During our biometry, we never look very closely. We just look at the IOL power and forget the rest. Intraoperatively, shallow AC, viscoelastic appropriate. Consider a tap, but I am not very convinced about that in all situations. Sclerostomies. Surgical risks are expulsive hemorrhage, uveal effusion, or malignant glaucoma. So recognizing this is the most important thing. Everything is small in the anterior chamber, and there is a high lens proportion is much larger when compared to the rest of the eye, and there is increased retinochoroidal scleral. So today all patients with a short eyeball undergo a B scan, and we measure the retinochoroidal scleral thickening. Phaco in anterior chamber, all the basic steps: perfect wound, anterior place wounds to prevent iris prolapse, use heavy molecular weight viscoelastics, protect the cornea, increase the bottle height if required, raise the IOP, low vacuum, low flow rate, and do a spiral or double rhexis, use a microforceps for that one. The special considerations: anything less than 22 millimeters, I ask for Diamox preoperatively. Anything less than 20 millimeters, I ask for Diamox plus mannitol pre-op. Prefer to give a good block, because if things go wrong, these patients experience pain as the expulsive is happening, and so they will be very uncomfortable, and they will strain and worsen the problem. So prefer to have a block, but after a block, give a very good digital massage, adjust the phaco parameters, consider the appropriate IOL power. Pars plana vitrectomy is supposed to preempt the choroidal detachment and creating space in the anterior chamber. I am not convinced by that. Sclerostomies is what I prefer, especially if the retinochoroidal complex is thicker, more than 1.9 or something like that millimeters, is better to have it pre-prepared and ready. Why does vitrectomy precipitate a choroidal detachment? That's a normal eye. Here you have some amount of effusion going on, and if it was a ECC kind of thing with an open wound, it will proceed all three posteriorly also, and then you get the altered glow as your first warning. But today we are operating in a closed chamber, and that doesn't happen often. So at this stage, if you decide to go and debulk the vitreous pressure comes down, but there is no amount of pressure you can put over here to push everything back, the lens iris diaphragm back. So what happens is this is already under tension. It is like you have released the weight on the pressure cooker, and that converts the incipient expulsive to a frank expulsive hemorrhage. So what does sclerotomy do? It allows this to drain out. And in a closed chamber, you don't get the posterior thing happening. What will happen is ciliary body area blood collection rotates the ciliary body, AC becomes shallow, and glow will continue to be good because it is not gone up till here because you are operating in a closed environment. Okay, so sclerotomy is what I would suggest. And the sclerotomy technique to perform is 1 millimeter behind the limbus, 1 millimeter incision, which is basically a radial incision, and you can use just your side port or something itself to keep cutting down till you see the brownish uveal tissue. You don't necessarily need to use a punch, but you need to create a space there and cause the blood to flow out. And my present thing for this condition, which is acute intraoperative rock hard eye syndrome, is differential diagnosis is aqueous misdirection, which we would like to happen, but which happens much less frequently than we believe. And we believe that expulsive can never happen to us. It happens only to other people. Okay, so think that it is expulsive that's happening to you. Prevention is better than cure. Diamox and mannitol preoperatively, like I said. Have the high molecular weight OVD ready. Have a sclerotomy ready. If you are not comfortable doing yourself, get a glaucoma colleague to do that for you. And treatment, fight to live another, live to fight another day. Okay, so don't try to be heroic that day. Close, put sutures of all main port, side port, everything. Put the patient on mannitol and plan for secondary safe completion either later in the same day or on another day. If you want to do any tap or vitrectomy, you have to have proof that there is no expulsive, otherwise you are in trouble. Thank you.
Thank you, sir. I just have a doubt, sir. Is there any increased risk for aqueous misdirection in people who have got coloboma, iris coloboma, where the zonules are weak? Or
so in terms of all patients with a lax zonule can potentially have fluid going back. So what I would suggest in cases like a coloboma, where you know that there is one area of weakness, you put viscoat. No financial interest there, but viscoat is, don't use anything else. Use viscoat, plug that area, seal that area, and especially if you are planning to do staining of the anterior capsule, it will prevent the trypan from going to the posterior segment and altering the glow. So plug that area, then you are okay.